team can go first, or
Yeah.
choose if they want to go first or second, I guess.
Yeah. All right, so the two teams should come up.
Yes.
All right,
Unfazed
doppelgangers.
rays and doppelgangers. And we'd have like a fight song coming up if we could, but
We could have hang out sleepy. I don't want to hang out sleepy.
we really kind of decided.
Yeah.
All right, so if you guys want to come over here. All right. So I will let you guys pick first on 1 through 20. I'm sorry, we have 20 songs, not 12.
Well, yeah, but we're only gonna do 5.
Unless we need to, yeah. All right. So what number would you guys like on 1 through 20? 4.
What's the flow of those one?
Taking turns, yeah,
Okay.
taking turns. Yeah, we guys will be here.
There's like 24.
Yeah, yeah.
Okay, they'll be.
All right, your STEM is you have a patient with a history of atrial fibrillation. Scan and choose a therapy.
Chad, you're
Go
our
for it.
expert.
Are we timed?
Scan your apical cord into the chamber. Sorry. Talk us through what you're seeing up there. You don't.
All right, so we're looking in the near field. We have ventricles.
They've identified a thrombus in the ventricles. What they're saying.
Low molecular weight.
So
Let me know when you're ready. So they've chosen to anticoagulate this patient with atrial fibrillation in a large clot. How's everybody feel about that? Yay. They're not going to die today from their massive stroke. You didn't kill your
Not
patient.
from their embolic stroke.
Yeah. They're gonna die from their
They
hemorrhagic
may
stroke.
die from their hemorrhagic.
When they fall out of bed. All right. Good job. All right. What number would you all let have? 7. Okay. All right. A 28-year-old female with a history of IV drug abuse and alcohol abuse is in septic shock with 3 weeks of fever and chills. Choose a parasternal view and make a diagnosis. Oh, have to use a parasternal. Oh, yeah.
This would be a lot more fun.
This should be a space.
Would this be great?
Oh, man. I would not
You'll-
With eyebrows.
You only get one parasternal sticker.
Yeah, we just decided we lost control. Picking a parasternal short axis right now, and moving left hand to right axis. The screen. And I'm looking at the muscle right now. And I'm tilting the probe to visualize the tricuspid because my suspicion is that patient might have vegetation on the tricuspid valve. I'm not seeing. So I'm seeing hyperechoic. Maybe vegetation. I'm just going to go through. Yeah, I'm not seeing anything with the mouth now. Everything So that I use it. So I'm going to tricuspid. Let me know how to actually do tricuspid edge. Which edge?
Very good. All right.
Wait. I don't think that was, did you see it at the education? I just saw it. There was.
All right. Number. It's hard to see. Tricuspid valve is hard to see with any of your peristernal views. TEE is usually your scan of choice when you're concerned about valve pathology. But sometimes you can see it from your aortic views. Six, sorry. I'm not listening.
So right now it's 1-1.
Scan the abdomen and find a pathology and state 2 characteristics of patients who should be screened for this problem.
Why did you just choose one? Oh, this one.
Yeah,
Supposed to scan one of the.
Oh, just one of the symptoms.
Oh, I
got it. And then just find out the pathology of the time of patient.
Yep, and tell me 2 characteristics of patients that need screening for this. You have your measurements on the side, so you can use that to help you.
Left side.
Left side.
Or view.
You don't
Oh, it rotates.
Yeah.
There we go.
So they don't know the sound is more.
Oh, it says right there, 4.73.
Yes. But our diagnosis would be a AAA, and 2 characteristics of people who should be screened are older patients and patients with smokers.
Alright. You're too good. We need to miss something. We need to. One I need. Alright. All right. Your patient is a 23-year-old G2P3 at 38 weeks gestation, presenting to the ER with acute chest pain. Scan her right and left chest and choose a therapy.
Okay.
Ready for the next B line.
Rural sliding. A lot of B-lines, so three or more in pelvic space is pathological. So that. So it's again, we just need. Control slide. So as the patient has interstitial edema on both apices, we're thinking about she's a lady from it. Okay. Do we have a blood pressure?
Just your ultrasound.
Yeah,
Would you like a blood pressure?
I would, because one of the medications I want to do is
Okay, the blood pressure is like, 160 over 100.
would you like to have a doctor?
Yeah.
Can we say what the diagnosis is?
Yes. Yeah.
Okay, we're thinking heart failure, secondary to perhaps pulmonary, a pulmonary embolism, but we want to check how the DVTs before we make that diagnosis, and check the right ventricular capacity and ice as well. Okay, but that looks like CHM as it's bilateral to according to the blue protocol that she's done. It is.
So it's pericardium cardiomyopathy. I agree with you on that. Nitro's not usually our but I was leaning towards BioPAC and then this with pulmonary edema. That was the plan of choice on mine. So, I can celebrate it. Unless they got my veto power here. So it's pericardial cardiomyopathy with heart failure. And I tend not to use nitro, and I consulted for pregnant patients as well. I could use non-invasive positive pressure if I can, and other drugs of choice to bring down their blood pressure.
So pulmonary embolism would give you all those findings. That wouldn't be pulmonary, so it would be right heart strain and so forth, trying to complicate. So if you give it right heart strain, this is cardiomyopathy.
Everybody see the pathologic findings here though?
Everybody sees
There's
the B-line.
lung sliding, and there's B-line artifact, which is coming down from the pleural line. And so it's correctly identified. And if you have more than 3 B-line artifacts, it's risk for pulmonary edema. And the patient has bilateral pulmonary edema. If it's unilateral, you worry about other causes of interstitial edema, like maybe pneumonia, focal pneumonia or something.
Early pneumonia tends to look like interstitial edema before it fully consolidates. Sometimes that's all you'll see if it's not doesn't extend all the way out to the periphery. Sometimes all you'll see for your pneumonia is pulmonary edema.
So if you have a pneumonia and alveolar fluid, it'll obliterate the pleural line. It'll look like a, we call it a shred sign. Look like the hepatization. But if the pneumonia does not go to the pleural line, and there's a millimeter of air, then you see B lines because there's more fluid in that lung, and the common tails will propagate all the way down. So, pneumonia does not go to the pleural line. It gives you B lines asymmetrically. But B lines on the right, B lines on the left is pulmonary edema from interstitial fluid. You ready for the next one?
Yes, next case. Yes, the other point that was made is delivery is obviously she's full term. And the problem with this is about only 50% of them resolve, and 50% of people have chronic heart failure from pregnancy alone. It's not from hypertension or pregnancy, it's not that they have heart problems in this, it's just this lovely blessing for the body. In many ways.
All right, we're gonna go with 13.
45-year-old man, 2 weeks of epigastric pain and 5 days of progressive nausea and vomiting. Scan the right lower quadrant and make a diagnosis. It's a 45-year-old male with 2 weeks of epigastric pain, 5 days of nausea vomiting. Just to double check that.
Yeah, can you see that specific?
All right. We're gonna go with bowel obstruction.
You are correct. So this has become one of my favorite ultrasound diagnoses. Is people get CAT scan, CAT scan, CAT scan. Bowel obstructions are so much fun to find, and it's just like easy. You mow the yard in their belly, and all of a sudden it's like this big distended belly, and it's the best sign in the world. My resident calls it the poo and fro, where you see the stool contents going back and forth. So not only will you see those big loops of bowel, if you remember from anatomy, peristalsis should only go one direction. So we start to see the poop going back and forth. They also call it the poop waterfall. I've seen mentioned, I think in the SAEM lecture, that's what they call it, where you see like this stool like floating around in this very edematous fluid-filled bowel. And sometimes you can find the transition point, not often, but a good sensitivity, not super high, or excuse me, good specificity, not super high sensitivity. So we are actually trying to find a way here to put it into a protocol with our surgeons. Our surgeons are on board with bowel ultrasound now because we're radiating the crap out of some of these cancer patients, so we'd like to stop. All right. Questions at all? Normal bowel, less than 2.5 centimeters, over 2.5 centimeters, that's when we start to think it's dilated. If you don't see any motion, ileus, if you see the poo and fro motion, then you worry about SBO. Ileus tends to not get as distended as the SBOs, but can get equally distended. You can also at the end start to see bowel wall edema where the wall starts to get extremely thick. You can see what they call the keyboard sign where you see the plica starting to get very pronounced within the fluid-filled bowel as well. All right, you are working in the ICU and you receive a 57-year-old man in shock. As you transfer, scan his subcostal view and decide what caused his shock.
Right, there's 3 and doppelgangers have 1, 2. This is their third scan. Yeah, they have 1. This is their third scan. Yeah. 3, 1, but I think that's.
And after this, to make things a little more challenging, we're gonna go down to time.
Yeah, and
Rounds.
we get to use one super fun stopwatch.
Right. Can everybody see that? See the pericardial effusion? And does a pericardial effusion alone mean that there's tamponade? So what do we need to see, which is what they went back for? That right ventricle wall, right, collapsing during diastole. So when it's supposed to be big and fluffy and full, if you can't tell because their heart's moving too quickly, or because you're just like, I'm not quite sure if we're in systole or diastole, you can use an M-mode tracing, where you can also look at the left ventricle and see what the left ventricle is doing on the distal portion of your M-mode tracing, and then at the top portion, see what your RV is doing at that exact same time. So that's kind of a way, if you're like, I think it's collapsing, but I'm not 100% sure if it's true, tamponade. The other thing too is if you see your heart like floating around like this, that's also not a good sign. The smaller the effusion, the more likely it is to cause tamponade physiology, because those are usually your more rapidly accumulating effusions, which is why we see tamponade more commonly in like traumatic situations rather than with our cancer patients and stuff like that, where you get malignant effusions. Those tend to be huge effusions, but no tamponade physiology because they've accumulated over time. The pericardium's been able to stretch to accommodate them. Very good. All right, so now we're going to go to a minute per round.
I have a super egg timer.
You got to make it interesting. You guys are too good. Pick the number. So we have 3 to 2.
All right. Ready, set, go.
Wait, we don't even have dates.
Never mind, that's about it.
I haven't even picked the number yet. 16. Jen's really easy. You have a 65-year-old female who fell from standing. Scan the right wrist. It says wrist, but I'm going with wrist. And name 2 risk factors for the pathology you see. We actually have to see the pathology. You can't just go based on the scan. You want me to rotate it?
All right, 27 seconds left.
$15. 2 risk factors.
2 risk factors. Osteoporosis and so, well, postmenopausal damage.
Okay. I think goes yes.
All right, hands up.
So theoretically a pathologic fracture, right? Did everybody see that difference where you see the white line and then the other white lines up here? Fractures you can be identified with right there. You can also use this to guide if you're going to do like a hematoma block. This is a great way to do it. So you're not just jabbing until you maybe aspirate some blood. It's not the point of the step off and most pain. You can actually look where you're poking a needle. If it's my body, I want you to know where you're poking a needle, not just poking a needle. So the white line on the right and then the nice straight white line on the left is your disruption in your cortices. Right there. So other risk factors, malignancy would be up on there. Kidney disease, yeah.
All right, next one. All right. 14. Four.
I'm not used to it.
That's okay. That's the only reason we're down.
I don't remember what other numbers have been used.
Oh yeah, that's your two.
You want to hear the numbers left?
There we go.
Okay.
They wanted 9. You are. Yeah, you didn't. That was your last one actually that you did.
10.
Your patient has sudden loss of vision in her right eye. Scan and make the diagnosis. His eye is below his forehead in my book.
I would ask the patient to look right and left. Okay. And I would probably increase the gain as vitreous tumors through this eyes with gainers now.
We do have that yet.
30 more seconds.
30 seconds.
We're going with retinal detachment.
Okay. Did everybody see that flap back there? Did anybody not do the no?
I didn't see that.
Thanks. Yep, we're pulling it up right now. So she was absolutely correct. See that nice little flap right there? So when when his real eyeball would look left to right, you would see that undulate like a worm, and that's your sign of retinal detachment. She's completely correct that your vitreous hemorrhage can look very similar to it. So as you turn it down, your vitreous hemorrhage should go. You should still see your retinal detachment there. So you go all the way up with the gain on your oculars and then slowly turn down as you look at pathology. And movement is extremely helpful. So right here, movement of the eye. Very good.
The other thing real quick to note about these is that retinal detachments are always anchored at the optic nerve. Whereas if you see that membrane is coming off the optic nerve, that's the vitreous detachment. Okay, so again, retinal detachments always anchored anteriorly at the oris serrata and then posteriorly at the optic.
And if you're really good, you can tell if it's macula on macula off. But I haven't gotten myself to that. All right. Team 4.
What's that number?
17.
Let's do 17.
All right. Your patient has an exquisitely painful left thigh. Scan the area and make it the diagnosis.
Use some analysis.
Let us know when it's 30 seconds.
30?
Yeah, yeah. Sorry.
Do you see any numbness in the brain?
15?
Yeah,
3, 2,
we'll get cellulitis.
So I was incorrect.
Yeah.
So there's actually a fluid collection there, which is she's right over up here. So that's an abscess with debris within it, yeah. And then when you see something that looks like a fluid collection, you want to put flow on it to make sure you're not over a vessel. You can also sometimes see increased flow around abscesses. They have a slightly hyperequilibrium around them, but you shouldn't see any flow internal. You want to compress it as well to see if there's any compressibility. Sorry, I'm like an nutrition. Okay.
The score is now tied, Beverly.
Yep.
Oral.
So the next one wins. Your patient presents complaining of a few months of heart palpitations. Scan the neck and state the most likely diagnosis.
Shouldn't this really report 3?
Yes.
Oh, yeah, yeah. You're right.
That's not my strongest suit.
Oh, it's the other problem, guys.
She didn't get to add the whole day though, I promise.
This is just.
I just did all the
Yeah,
whole day.
no, I love it. Thanks. Yeah, no problem.
How long do you have? Okay. 30 seconds. Actually, a thyroid cyst. That was the actual diagnosis. But you wouldn't be able to diagnose necessarily based on. So you want to see the pathologist. Yeah, you have to. Thyrotoxicosis would be by lab and clinical picture, but scan the diagnosis would be that pathology causing. All right. Potentially.
Oh, did they?
We didn't really ask what happened.
Oh.
I'm so sorry.
What the discussion was.
So it was heart palpitation, and they said thyrotoxicosis, and we talked about how the actual diagnosis is thyroid cyst. The thyrotoxicosis is more of a lab value and clinical picture diagnosis that what we're trying to diagnose with the ultrasound is actually the cyst that's potentially causing the diagnosis.
You guys see those cysts? Doctor, no flow in those. This is your what?
Carotid.
Right, exactly. Here's your thyroid gland. This is the right node of the thyroid. What you're seeing is a cubic system.
Number?
What was number 20?
Sorry, I think I have, but not, yeah. 35-year-old female with fever and right upper quadrant pain. Scan the right upper quadrant and make a diagnosis. Especially blue sheet. You lose if you break blue sheet. Oh.
Just think of the letter.
Oh, just have to, that's the figure for it, yeah.
Um,
30 more seconds.
35-year-old female with fever and right upper quadrant.
cholecystitis.
That's correct. Now, what you really want to do is when you're scanning, so you see the gallstones, because everybody see those, the bright white with the shadow. You also want to make sure to measure the wall for the wall thickness. You can also see pericholecystic fluid, but the big one that our model obviously doesn't have is a sonographic Murphy sign. So a sonographic Murphy sign is your one of the more sensitive findings for cholecystitis. So your anterior wall is where you typically measure, And the reason why is you can get posterior acoustic enhancement in that posterior wall, so it's gonna appear falsely to air. So your anterior wall is the most reliable. Greater than 4 millimeters. And then you could also potentially go down and look at your common bile duct, also greater than 4 millimeters as well.
Oh.
So this one is almost a centimeter.
It's almost 10.
So that's not normal. Not normal at all.
Can you guys see anything else wrong with this? Gallbladder wall thickening, what else? Very close to this fluid. There's actually, there's 3 stones here.
The stone of the.
See two here, and there's
And
actually a
there's
stone
like
impacted right here in the gallbladder net. Right? It's probably the one causing all the trouble.
And that's the one a lot of people miss. So if you don't see the gallbladder neck, you might say they don't have gallstones. But most gallbladders aren't as easy to find as any of you who did the gallbladders at the end of the day did. But they can kind of hide behind the bowel. The duodenum, if it's fluid filled, can look like the gallbladder, so you really need to kind of keep an eye on it for peristalsis as well. So I think that's it. We have 5 to 3, is that correct? Give a big round of applause to both of our competitors. I've seen them compete nationally. I know they're rock stars. So,
All right,
You
the
want-
winner is all win gift cards.
yes.
I mean, I think that's deep.
Can Dan just demonstrate the other pathology real
Yes.
quick? Just to go through that?
And I'd also big round of applause for Dr. Katz, who brought this wonderful meeting. So all of you guys for braving the snow, thank you so much. We really appreciate you coming. We think our work would be useful without you.
But I promised some just additional pathology for you folks that wanted to see pathology. So you already saw what the retinal detachment looked like. This is something that you could potentially see from a blast injury. This is a patient who came in actually with an intraocular foreign body right over here.
Ooh.
You can see it right there. That's the optic nerve seen over here. And there's the foreign body seen in the posterior chamber.
And when you see a foreign body, that's usually a good time to stop scanning and putting any pressure on the eye, because then you also worry about globe rupture potentially. So if you find one on accident,
Save a picture.
they will click and stop.
This is a patient that came in with shortness of breath, dyspnea, history of cancer.
Anybody? Let's just talk it out before he gives an answer. What do we think we see here? What's this? What's this?
It hurts spleen. That's where are we?
Yeah,
What's
I think
this?
you're winning.
What's this?
Fluid.
Fluid.
Very good.
What should we see back here if we're normal? We'll see an inflection. What we should see on a pleural fusion? Spine sign, spine marching up. Next.
This is a patient that had acute right flank pain. Came into the ER
Flank pain.
and then got some Toradol and then felt better.
What is this structure? Ladder. What's this? Okay. What color is it? What shape is it? Where's it located? What is next to it?
It's also got some shadowing. We saw some shadowing just a second ago from something else.
Right?
It's a stone that's passed into the bladder. This is a patient that came in asymptomatic, no real complaints. She got a scan.
What's this structure? Remember, note this orange. It's a kidney. What's orange on ultrasound? What kind of Doppler?
Color.
It is a form of color. There's 5 forms of Doppler. Which one is this? Color Doppler is B-A-R-T, blue away, red toward. This is orange. What kind of Doppler is that?
Out.
Pulse wave gives you a waveform. Oh,
This is power.
power Doppler is orange. Power Doppler is sensitive. So it's shown as there's flow here to the inferior pole. What's up here? Why?
Because there's nothing in it. It's smooth walled and full of anticoagulation, there's no modulations,
So there's three components of simple cyst. So it's anechoic, it's smooth walled. What's the last one? Post-air acoustic enhancement, so a simple renal cyst.
Good, so someone earlier
Thanks, guys.
Someone earlier mentioned a soft tissue diagnosis.
He's on the leg. We're looking here, linear probe. What's this?
Cobblestone.
Looks like cobblestone.
Cobblestone. So the diagnosis is, what would you do if you're saving this exam? Is go up to normal tissue, see what normal tissue looks like, and then scan down over the area that's affected, and then you can do dual screen and show, or video, show the difference. But thicken, and then cobblestone fluid in interstitial space.
Just to compare real quick to the previous one that we did, this was the complex fluid collection. It's good. This is a guy that was a skin popper who came in with the abscess. All right, we're going to do one more before the final bonus one. So this is a patient that came in with knee swelling. So I'm scanning actually over the patella. I heard it. Somebody said it. Pelvitis. Very good. All right. So this is a college kid who was involved in a hazing incident. Okay, and he was asked by his friends to swallow a foreign body. He's got a foreign body in his belly. Well, let me do the full sweep here. You guys ready? There you go. I heard it.
Wrong. Oh my gosh.
Right.
Oh,
All right.
Sorry.
Fantastic. Thank you very much. Thanks,
Thank you guys already. We have one last announcement. We did from a pool of judges, from your scanning and from their knowledge, this year's Sonographer's Cup, the 2015 version, goes to Nick Keller. Thank you guys for coming. It's been fantastic. I also want to thank Dr. Rob Blankenship for that amazing talk this morning. Really inspirational. Why don't we look at the evidence? I think that's fantastic. Risa Lewis, if anybody's interested in emergency medicine and ultrasound, she's the ASAP chair. She's a fantastic educator. Some of you guys will see her. Craig Bolger, who put all this together. She's actually on maternity leave. She does more work on maternity leave than people that do full time. So it's unbelievable. Thank you guys all for coming. We're really excited about this, but we want to have this every year. We want to try to make it even better, but thank you guys for coming today. And please let us know. I think Craig's going to send a survey out to all of you.
Yeah, we'll be sending a survey for feedback. You know, we want to make sure we get, next year better than this year, and that everybody would love to have you back. And like I said, if you guys want to get more resources at your place, grab one of the brochures. Both of our emails are on there. We'll be happy, because the trifold brochures have all of our information on there. And we'll be happy to help get you set up with resources, people, whatever you need. We will help get you to the right places. So we want you to keep doing it beyond today, and as much as you can in the clinical setting once you get there.
And be safe on the way home. But
Yes.
thanks again for
And if you
coming.
don't feel safe driving home, let one of us know. We have plenty of houses for you all to stay in. So just let us know, and we will get you